So, an increase in white blood cells. An increase in white blood cells. This is the beginnings of the interpretation of lab results and whatnot. So, what does the increase mean? We have to know what normal is first. So, a normal white cell count is 4,500 to 11,000 white cells per microliter. The normal ranges may vary slightly, but that's your rough estimate. And you should always be given the normal ranges in any good lab. They'll give you the normal ranges. But in terms of interpretation, Cambridge won't test leukopenia, but leukopenia is a low white cell count, below 4,500 per microliter, and leukocytosis is a high white cell count, above 11,000, higher than 11,000 per microliter. Now, for Cambridge purposes, we only need to distinguish between two major causes of leukocytosis. We don't need to talk about any of the other dozens of other things it could be. Many dozens of other things it could be. So, an infection will typically raise your white count significantly, and leukemia will raise your white count very significantly. So, let's talk about infections first. A normal white blood cell count with differential. Reminder, the white blood cell count, 4.5 to 11 per nanoliter. I just changed the units. Unit conversion, multiply by 1,000, and it's 1,000 microliters, or it's 1,000 nanoliters per microliter. So you multiply everything by 1,000. So just a reminder on how to do conversions, back to your Unit 2 stuff. It is 1 milliliter or 1 millimeter equals 1,000 micrometers. 1 milliliter equals 1,000 microliters. 1 microliter equals 1,000 nanoliters. And one micrometer equals 1,000 nanometers. So for magnification, you use meters, and for volumes, you use milliliters and microliters. So when we're dealing with the very small, micro is what we usually deal with. But I converted my units, and we're always multiplying by 1,000 when we do our unit conversion. Since it's cells per microliter, then microliter is on the bottom. In order to convert, we divide by 1,000, and I was right the first time when I wrote it on the slide, and I shouldn't have second-guessed myself. 1,000 nanoliters per 1 microliter, and the microliters cancel out, and the 1,000 cancels out, and we move the decimal point over, and then we end up with 4.5 cells per nanoliter. So that's our unit conversion, because our microliter is on the denominator. We convert by dividing by 1,000. For magnification, making things larger, if we are starting from millimeters, then we convert 1 millimeter into multiply 1,000 micrometers per 1 millimeter, and then our millimeters cancel out, and we end up with 1,000 micrometers. So we always multiply. It's always by factors of 1,000. It's always by factors of 1,000. You'll never be asked for anything other than factors of 1,000. And it's milli, micro, nano. Millimeter, micrometer, nanometer. Milliliter, microliter, nanoliter. The liters are far less likely to be tested. But you should know the the prefixes, the scientific unit prefixes. So, in a differential, that's the new term on this board. A CBC is a complete blood count. A differential is the different blood cells present in that CBC are given as a percentage. You'll actually get the raw numbers as well, but the percentages thereof are around these numbers. These numbers are not precisely Cambridge exact numbers, but these numbers are roughly true. These numbers are true, but they are not Cambridge exact. So your neutrophils will be 55 to 70% of your circulating white blood cells. Your band cells are young neutrophils. They are the ones that have been most recently produced by the bone marrow. Your lymphocytes will be 20 to 40%. Cambridge says 15 to 40. Close enough. Your lymphocytes will be up to 40% of your circulating white blood cells. And monocytes will be 2 to 8%, eosinophils 1 to 4, and basophils, your least numerous, 0.5% to 1%. Children under the age of 4 will have a higher percentage of lymphocytes, and this is a result of the thymus gland being in play, among other things, but that's a factor. So now that you know the normal, let's talk about the abnormal. In a bacterial infection, the first responders to bacteria are neutrophils. So an increased overall white cell count is inevitable because in all bacterial infections, except for severe septic shock, you will have leukocytosis. So you'll have an increased overall white count. Your percentage of neutrophils will increase because the first responders to a bacterial infection are neutrophils. They are phagocytes that respond to bacteria, engulf them, and then explode, releasing their cytotoxic guts everywhere, further destroying invading pathogens. You'll also have an increased percentage of bands because in order to produce more neutrophils, you have to produce them from the bone marrow. Where are they coming? If they're coming from the bone marrow, then they are coming out young from the bone marrow, which means they're coming out as bands. And those bands mature into neutrophils, and those neutrophils do their job. You'll also have an increased percentage of lymphocytes during chronic bacterial infections. Chronic bacterial infections, and this is the result of an increased humoral immunity and cell-mediated immunity response. The specific immunity is kicking in. That's when your lymphocytes increase. In tuberculosis specifically, because tuberculosis kills macrophages, and macrophages are matured monocytes, your monocytes will increase in percentage in the circulating blood. You will experience monocytosis. So anytime you have an increase in a white blood cell, you will have that blood cell labeled as the blank cytosis. So an increased percentage of lymphocytes will be lymphocytosis. An increased percentage of monocytes will be monocytosis. An overall white cell increase, leukocytosis, because leukocytes are white cells. In a viral infection, you will also have an increased overall white cell count. The percentage of neutrophils will decrease. The reason the percentage of neutrophils decrease, the absolute number of neutrophils will actually remain stable. They will actually remain the same. No change. There will be no change in the absolute number. But the total number will increase. So when you have the same denominator, 1, and the total white blood cells changes from 50 to 100, suddenly you've gone from 2% to 1%. You have a decreased percentage, but the same raw number. So that's where that decreased percentage is coming from. Neutrophils are not active in fighting viruses. Neutrophils are not active in fighting viruses. Your total white blood count increases. Your total white blood cell count increases. But your neutrophil absolute count stays the same, which means the percentage decreases. That's how you would explain that if you were given 8 percentages. Describe and explain the table of white count in this viral infection. Describe and explain the CBC with differential shown in chronic viral infection. You'll have an increased percentage of lymphocytes because lymphocytes are active in, especially T cells, are active in the immune response to viruses, especially because your monocytes differentiate into dendritic cells and macrophages. Dendritic cells are active in engulfing viruses especially, but they only account for 2 to 8% of your white cell count. That's not a large number, and they exist in the tissues anyway. So since they are in the tissues, they are not present in large quantities in the white, they are not present in large quantities in the blood. So you may have a monocytosis in some viral infections, but not all of them. Why the lymphocytes are increased is because monocytes become macrophages and dendritic cells, which are antigen-presenting cells. What are they presenting the antigens to? B and T lymphocytes, which divide and differentiate upon activation or sensitization once they are exposed to their antigen. So lymphocytes, which do account for a large percent and do circulate through the blood in larger numbers, are expanding. And that is why. That is where you get the increased white count. And that is where you get that lymphocytosis from. Cambridge will be testing you on different kinds of leukemia. The amount of detail, I'm not 100% sure how much detail, but we're going to break this down. There are 4 major types and 1 rather rare type of leukemia to be concerned with. So we can break this down by the course of the disease, where there's an acute and chronic time course. And if you recall from our discussion of diseases as a general rule, the acute time course, they progress rapidly and they happen over a short period of time, whereas chronic diseases happen over a long period of time and progress rather slowly. Now, we can also divide them by their progenitor cell type: lymphocytic leukemia and myelogenous leukemia. The lymphocytic leukemias originate from the lymphoid progenitor cells, and the myelogenous originate from the myeloid progenitor cells. So the lymphocytic leukemias are the lymphoblastic type, and the myelogenous leukemias, the myeloid or non-lymphocytic type. Your lymphocytic, your lymphoid progenitor cell produce B and T lymphocytes. Your myeloid progenitors produce monocytes, neutrophils, basophils, and eosinophils. So, making a grid pattern, we have acute lymphoblastic leukemia, acute myelogenous leukemia, chronic myelogenous leukemia, and chronic lymphocytic leukemia. In this order is the age range of patients that they are typically present in. So from youngest to oldest, the youngest patients will typically have the acute leukemias, and the oldest patients will have the chronic leukemias. Youngest patients, acute lymphoblastic, and oldest patients, chronic lymphocytic leukemias. Acute myelogenous, typically the younger teenagers and adults. Chronic myelogenous leukemia, older youths and young adults rather, and middle age. Hairy cell leukemia is a rare type of leukemia that affects primarily B cells. It is a B cell leukemia. Cambridge can test you on these. I'm not sure 100% about hairy cell, but one of the medications that they refer to later specifically targets B cells, and it's used to treat hairy cell leukemia. So I wouldn't be surprised if you saw hairy cell leukemia as a question. It wouldn't be out of the ordinary. It wouldn't be out of left field. So in diagnosing leukemia, the first thing you do, very much like an infection, you order a CBC with diff. The CBC, the complete blood count, the differential, the difference between the different types of blood cells found in that complete blood count. So it's an incredibly useful test in anyone that you suspect of, especially leukemia. Because if you suspect a problem with the white blood cells, you're going to want to know what your disposition of your white blood cells are. What's your organization of them? So for the acute leukemias, acute lymphoblastic and acute myelogenous, you're going to find some blast cells, immature cells, in your peripheral blood smear. And a peripheral blood smear is when you take blood from the peripheral veins and you smear it onto a glass slide and put a cover slip on it and then look at it. So you'll see immature blast cells, and you'll see a lot of them. In order to diagnose the chronic leukemias, it gets a little bit less simple. You require, for the diagnosis of chronic lymphocytic leukemia, a lymphocytosis of greater than 5,000 cells per cubic millimeter. Now, a cubic millimeter is roughly equivalent to a microliter. Now, remember that your normal white blood count should be between 4,500 and 11,000 cells, total white blood cells in a microliter. So, the amount of lymphocytes, which should account for 20 to 40% of your total white cells, is already accounting for the minimum threshold. The normal range is about 600 to 3,000 or so. So this is a lymphocytosis. You will see cytosis when you're talking about a large number, an abnormally large number of those cells. You will see a philia if you are talking about an abnormally large number of those cells as well. So lymphocytosis, monocytosis, leukocytosis, neutrophilia, basophilia, eosinophilia. Those are the different individual types of blood cell, large numbers. Leuko is white cell in total. And penia is a low number of all of them. So lymphopenia, monopenia, neutropenia, basopenia, eosinopenia, which you'll never see those because they're supposed to be in low quantities anyway. That would just be if you just added definitions together. But they're already supposed to be less than 1%, or 1 to 4% for eosinophils, and less than 1% for basophils anyway. So, your absolute neutrophil count in a chronic lymphocytic leukemia will be normal, usually. It will be typically normal. And neutrophils are not lymphoid progenitor. They do not have a lymphoid progenitor. They come from a myeloid progenitor, so of course they'll be normal. The red blood cells and the platelet counts will be mildly decreased. And we'll discuss that in a moment. And the bone marrow or peripheral smear will show that normal mature cells, but they'll be a little bit small, with lymphocytes that are less than 55% atypical or blast forms, as opposed to the acute lymphoblastic leukemia, where you will see a lot more. A lot more. Chronic myelogenous leukemia is defined by the peripheral white blood cell count. It's defined by its CBC with diff. If you have a CBC that shows leukocytosis and overabundance of total white blood cells in excess of 100,000 cells per cubic millimeter, more than 9 times the maximum range that we discussed before, 11,000, you're done. It's CML. Neutrophil precursors will be present in the blood. And when we say precursors, we're not talking about band cells that we discussed before, that we discussed when we were talking about infections. Band cells are immature, young, they're not immature rather, sorry. They are young neutrophils, but they are still ready to go neutrophils. They are still capable of performing the functions that neutrophils perform. They're just young. They are just recently produced by the bone marrow. Precursors means they're not even ready to be classified as neutrophils yet. They're not even ready to be classified as white blood cells yet. They're not white blood cells yet, and they're somehow in the blood. You've got what amounts to bone marrow in your blood. That's problems. This is also accompanied by basophilia and eosinophilia, high numbers of basophils and eosinophils. And unlike acute myelogenous leukemia, you will not see these as atypical blast forms, young, immature basophils and eosinophils. These basophils and eosinophils will be mature and functional basophils and eosinophils. Chronic myelogenous leukemia. Now, chronic myelogenous leukemia is defined by its CBC with diff. For the others, for the acute lymphoblastic and acute myelogenous, and for chronic lymphocytic, you need further diagnostic proof. You need further evidence. That evidence comes from a bone marrow aspiration. You take bone marrow from a location where bone marrow is present, those usually being the large bone structures, primarily the hip, the femur. The femur right here. And it hurts a lot. You have to literally jab a needle through the skin, through the muscle, into the bone, through the layer of bone, break through that bone, and then siphon off some of the bone marrow, and then pull it all the way out, hoping you don't give them an infection along the way. Hoping. Now, in acute lymphoblastic leukemia, that bone marrow aspirate that you just took will be mostly lymphoblasts, immature lymphocytes, instead of healthy bone marrow tissue of precursors to all of your other blood cells. It has overgrown and replaced almost everything else. For the diagnosis of acute myelogenous leukemia, you will see a large amount of myeloid progenitor cells, but one of the main things that you'll see are Auer rods. Auer rods, AUER rods. Now, these are cytoplasmic inclusions that look like these lines, these heavily staining lines present in the cytoplasm. Those are virtually diagnostic of acute myelogenous leukemia. You rarely need to see anything else to be convinced that it is AML. However, it is not pathognomonic like Koplik spots or pathognomonic of measles, but it is very rare to find Auer rods in other diseases besides AML. It is unlikely. You're typically going to find Auer rods as part of AML, packaged in AML. So they're certainly not going to appear in acute lymphoblastic leukemia. In chronic lymphocytic leukemia, as we said before, the lymphocytes that you get from this aspirate will be mature. Less than 55% of them will be atypical or in their immature blast forms. But there will be an excess of them. They will have more than 30% of their bone marrow be lymphocytes. Now, this is hairy cell leukemia, and I hope it's in focus. It looks blurry because they look hairy anyway. Under the staining, this is a trap staining, tartrate-resistant acid phosphatase. It's a particularly useful stain, and it helps us to identify hairy cell leukemia, among other things. Now, there's other genetic tests that you can perform, for example, looking for 922 translocation or various other things, but it's unlikely that the amount of points that you would get from knowing other diagnostic procedures will be the difference between you getting full credit and not getting full credit if you understand those other diagnostic procedures. You should have sufficient understanding of those other methods to get full credit from Cambridge on any kind of leukemia diagnostic question they should be able to throw at you with what we discussed already. Any further stuff is far beyond the level expected of you by Cambridge. So what happens to someone with leukemia? Since leukemia is a cancer of the white blood stem cell, and those stem cells are being produced and entering the circulation, are going to be dysfunctional and immature. A dysfunctional, immature white blood cell in circulation will not be effective in potentiating an immune response to a pathogenic invasion. As such, an individual with leukemia is going to be immunosuppressed. They will have a suppressed immune system. They will not respond well to infections. That means they are going to get sick. And they're going to get sick easily. Immunosuppression, a key term, due to dysfunctional immature white blood cells as a result of white blood stem cell cancer. Other bone marrow progenitor cells are also being disrupted by mass effect by these stem cell cancers. So the ones that take the hit are going to be platelets and erythrocytes, your thrombocytes and your erythrocytes. The decreased levels of thrombocytes will increase your risk of bleeding and delay your clotting. So you will have a higher risk of bleeding and it will take longer to clot. A decreased level of erythrocytes is the definition of anemia. And anemia's symptoms, as we have discussed in our previous diseases, are weakness, fatigue, and pallor. Paleness. Pallor is paleness. It's okay to call it pallor. That's not British. That's American. We call it pallor in America too. So, let's continue on to autoimmune disease, because we were talking about disease before. These are non-infectious. Now we're talking about non-infectious disease, so let's continue with some other non-infectious disease. The exact reasons for autoimmune diseases to occur is unknown. The exact reason is not known. But there are theories that it is immune-mediated. It is an antigenic response. An antigenic response results in a response to surface antigens to body tissues. So the body is being treated as non-self, even though it's self. The surface antigens on the invading pathogen were similar enough to the body's surface presenting markers that the antibodies to that pathogen are also able to bind to the body's tissues. And when that occurs, all of the things that the antibodies do for you against invaders, neutralization, opsonization, and complement activation, will occur against your own cells, as well as allowing for a immune-mediated response, humoral and T-cell mediated immunity. So you're essentially creating an immune response against yourself. Auto, self, immune, disorder. Autoimmune disease. You are treating your own body with an immune response. Now, there are some risk factors associated with the development of an autoimmune disorder. These are by no means a guarantee, and this doesn't mean that those who do not have these risk factors cannot have an autoimmune disorder. Being female, being young to middle age, being African American, American Indian, or Latino, or Latin American rather, having a family history of an autoimmune disease, the exposures to certain environmental factors, pathogens, or medications have been linked to the development of autoimmune diseases. Myasthenia gravis, and these slides are a long series of bullet points about myasthenia gravis. I'm just going to talk about myasthenia gravis for a moment because it is the best characterized autoimmune disease. Myasthenia gravis is an antibody-mediated immune disease. It is antibodies form against the acetylcholine receptor. They form against the acetylcholine receptor results in postsynaptic inhibition. So your immune response is against the acetylcholine receptor, and when your neuromuscular junction is attacked, there's no communication between your muscles and your nerves. Your nerves sending signals to your muscles, the muscles do not receive that signal, and the muscles do not contract. Your muscles become weak, and you are extremely weak. It is relatively uncommon. That is the prevalence, relatively uncommon. But it is the most common disorder of neuromuscular conduction, of neuromuscular transmission. Typically, 20 to 30s in females and 60 to 80 in males. And if you have an underlying, and those 10 to 15% of those with myasthenia gravis have an underlying thymoma. A thymoma is a benign tumor of the thymus gland. The thymus gland is the gland where the T cells mature. So there is a strong link between T cell activation here and myasthenia gravis. So there are other things that can be associated with the onset of the disorder, like viral infections like herpes simplex and hepatitis C. But primarily, there are two clinical forms, ocular and generalized. The ocular form is where your eyes close and you have the drooping eyelids. This is actually the most common weakness. Your eyelids will weaken and you will basically have to wait for your acetylcholine to build up high enough levels for you to open that up again. You have to wait for the receptors you have remaining to be freed up so that your muscles can activate once more. In the generalized disease, you'll also have the same symptoms as the ocular disease, but it can affect every other limb as well. So if you try and lift your arms, they'll gradually fall down. So ptosis and diplopia. Ptosis is the eyelids drooping, and diplopia is the double vision that results from weakened ocular muscles. The generalized symptoms, you'll have all those muscular weaknesses, and if the muscles that you take for granted, the chewing, the breathing, the lifting of the arms, the walking, all of those things you can't do for sustained periods of time. You have to sit and wait to recoup your energy and return. You become weakened. You may be, the mind may be willing, but the body is unable. So, basically your diagnosis of myasthenia gravis is focused on the clinical symptoms. You essentially prove that they have the muscular weakness to sustained muscular activity, the weakness to sustained muscular activity, and the treatment is immune mediated. You treat symptomatically with anticholinesterase agents, so you either increase the amount of acetylcholine so that they have more stimulus, so that they can produce more acetylcholine, or they don't remove the acetylcholine they have, or you weaken their immune system so they're not attacking their own neuromuscular junction. You can weaken their immune system with glucocorticoids and immunosuppressive drugs, and you can also use rapid immunotherapies like plasma exchange, which is called plasmapheresis, or intravenous immune globulin, IVIG. Immune globulins are antibodies. Or thymectomy, or thymectomy. If they have an underlying thymoma, there is often an indication. Now, the specific drugs, you don't need to know. If they give you those specific drug names, they will tell you what they do. And you will need to understand exactly why they are working. So if they give, because neuromuscular junctions and conduction is not part of AS level, they will explain to you how neuromuscular junctions work before they ask you any question about acetylcholinesterase. But the question they'd be asking you, if they asked you about the acetylcholinesterase inhibitor, like pyridostigmine, they'd be asking you about enzyme inhibitors. They can use an autoimmune disease to test Unit 1 information, like enzyme inhibition. They can use Unit 5 information to test Unit 1 information. Be aware of how these things can be used to test other units. How they can bring other things into context. They can use a question about bone marrow stem cells to ask you a question about mitosis. They can use a question about autoimmune diseases to ask you, or they can use a question about antibody effects to ask you a question about cancer or something, because one of those antibiotics might be a carcinogen. They can bring in old material and test you on old units in Unit 5. Now, let's start immune medicine. This is your basic structure of an antibody. The basic structure of an antibody includes 2 light chains and 2 heavy chains. Light chain, light chain. Heavy chain, heavy chain. And it's split into 2 regions. The constant region and the variable region. Or rather, sorry, the FC region and the antibody and the antigen binding region. There are 2 antigen binding sites, and these are antigen binding regions. but they are the antigen binding region. The constant region and the antigen binding region. Within each of these chains, within the light chain and the heavy chain, there is a variable region and a constant region. Constant region, variable region. In the heavy chain, constant region, variable region. The variable region is what makes up the antigen binding site. It's what makes the antibody specific for an antigen. The changes to the variable region are what make for the antigen specificity. The constant region allow for the cellular machinery to continue functioning no matter what changes have been made to the antigen binding region. So, the FAB is the antigen binding region, the functional antigen binding region. The FC region is the functional constant region. I'm not sure if it's functional or not. Just stick to FC and FAB. All right. These chains are held together by disulfide bonds. That makes this what kind of structure? We'll talk about that in a moment, actually. So, actually, no, let's talk about it now, and we'll go back. That makes this a quaternary structure. It has multiple chains. Multiple chains makes this a quaternary structure. Each individual chain has a three-dimensional conformation, which makes that a tertiary structure. A 3D conformation of an individual chain is a tertiary structure. And we can see here a beta-pleated sheet, here a beta-pleated sheet, there a beta-pleated sheet. There is an alpha helix there, 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 there, there. We see secondary structure. We can infer the existence of a primary structure by the fact that there are disulfide bonds, because a disulfide bond requires sulfur. And sulfur is only found on the R groups of specific amino acids, cysteine, and methionine, but cysteine is easier for us to remember because of our lovely cysteine curls. So, the existence of these disulfide bonds, and also the presence of this bound carbohydrate, which requires histidine in order to attach, we can sense that there is, in fact, specific placements of individual amino acids here, in very particular placements. Each structure is built upon the previous. So, quaternary is built upon tertiary, which is built upon secondary, which is built upon primary. Every part is built upon the next. And a prosthetic group is also present, making this a glycoprotein. A glycoprotein. It has a carbohydrate here bound, making it identifiable. So, antibodies. Antibodies are not to be confused with antibiotics. Please do not make that mistake. They are protein structures that bind to antigens. And if an antigen is called a toxin, it is an antitoxin. If an antigen is called a venom, if an antigen is a venom, it's called an antivenom. They're all antibodies. So they're glycoproteins. They're called immune globulins, IGs. And there are 5 classes. Each immune globulin has specificity for one antigen. And sometimes body tissues if an autoimmune disease is present. But simplify. There are 5 classes: IgG, IgE, IgD, IgM, and IgA. IgG is 80% of all immune globulin present in the body. It is circulating freely in the blood, produced by plasma cells, differentiated B cells that are plasma cells. It is responsible for resistance against viruses, bacteria, toxins, etc., etc., etc. IgE is a surface membrane bound antibody. It is bound to basophils and mast cells, and is helpful in allergic reactions, allergies. IgD is the antibody on the surface membrane of B cells. It is a surface membrane bound antibody on B cells. It is part of the sensitization process of B cells. IgM is the first class of antibodies that get secreted during a primary immune response. It is not particularly high affinity, but it gets the job done. When you need to agglutinate something, when you need to stick multiple antigens together into a clump, IgM does the perfect job. Because look, it's a little cluster. You stick something here, you stick another thing here, you stick another thing here, and another thing here. It's like the little connector bit. It holds multiple things together. So it's very good at agglutination, making clumps of stuff. It is not very high affinity. It is quite low affinity. You do not need to activate B cells with T helper cells to produce IgM. They can be produced from plasma cells without the activation by T cells. IgA is a dimer. This is a pentamer, by the way, and this is a dimer, 2, pent 5. IgA is found primarily in glandular secretions, mucus, tears, saliva, semen, also breast milk. And these antibodies attack pathogens before they gain access to internal tissues. Maternal immunity that gets passed on to infants after they are born can continue through IgA secretion through breast milk. But IgG is where the maternal immunity comes through the placenta. So the baby, when they're born, has maternal IgG for about 6 months. And if they're breastfeeding, they have maternal IgA as well for however long they're breastfeeding. And we'll talk more about what kind of immunity that is soon. Very soon. Now, this may be a little bit complicated, but it's fun, so let's talk about it. When a B cell first encounters its antigen, it will activate, and it will start producing IgM, low affinity IgM antibodies right away until it is activated by a T helper cell, and then it can differentiate into IgG producing antibodies, IgG antibody producing plasma cells, and memory B cells. If there is a secondary response, if antibodies are already present, an inhibitory signal will be sent to the B cell, telling it not to activate, and it will not produce IgM. It will not produce IgM. But a memory B cell will ignore that signal. It will still be stimulated, and it will produce it. It will clone itself and differentiate into IgG producing plasma cells and more memory cells without needing T cell activation. So a secondary response will produce considerably less IgM than IgG, IgA, and IgE. IgM is in high levels in only the primary response and in very, very low levels in secondary immune response. It's almost not there. So now, let's start by discussing hybridoma technologies. Hybridoma is a hybrid of a myeloma cancer cell and an antibody-producing B lymphocyte, which is the definition of a plasma cell. A B lymphocyte doesn't start producing and releasing circulating antibodies until it is a plasma cell. So a monoclonal antibody is a monospecific antibody that are made by identical immune cells that are all clones of a unique parent cell. Contrast this with polyclonal antibodies, which are made from several different immune cells. We do this, as I mentioned before, because plasma cells are what make antibodies, circulating antibodies. Once a plasma cell differentiates from B cells, they do not divide again. They are the final end stage of differentiating. Once differentiated, they will just make antibodies until they die a couple of days later. And a B cell, although it can divide, won't produce antibodies until it becomes a non-dividing plasma cell. So if you need antibodies for commercial purposes, then you won't have enough from simply B cells alone. And you need to make a hybrid of an immortal, constantly dividing cell and your plasma cell. And what do we know that is immortal and constantly dividing? Cancer. So myeloma fits the bill. Myeloma fits the bill. Myeloma for its immortality, and a B lymphocyte for its plasma, for its antibody production capabilities once it becomes a plasma cell. And from that you'll get a hybridoma, the immortal antibody producing cell. So we do this by challenging a mouse with an antigen. And then, after a while, we wait for it to develop this humoral immune response. The humoral immune response is the production of antibodies by a differentiated plasma cell and B lymphocyte into memory B cells. You know, that stuff we discussed before. And the spleen cells are what we harvest. Why the spleen? Because the spleen is a lymphocyte-rich organ. These spleen cells we will fuse with myeloma cells to form many hybridomas. We keep rolling the dice with these hybridomas, hoping to find one that is sufficient for our needs, that produces antibodies for what we want in sufficient quantities and is immortal and produces and divides in the quantities, in the rates that we need it to. So when we find an ancestor cell that suits us, an ancestor cell, we culture that ancestor cell and create a clone army. And from that clone army, we produce monoclonal antibodies in droves. We harvest lots of them. And then we can start pumping them into people. But wait a minute. I thought mouse antibodies are what we were making from that. Well, yes, we are. Aren't those non-self? Yes, yes they are. And that is actually a problem, because non-self antibodies are antigens to a human being when you put them in that human. So mouse antibodies are antigens to a human. They are non-self. And in the 1970s, around 1975 or so, when this technology was invented, the limitations of this technology were clear. These antibodies would only persist in the human human circulation for a short period of time until they were cleared. And once they were cleared, they would cease to be effective. Sometimes they could even trigger a serious immune response because they were non-human antibodies. They were an antigen. They could make people actually quite sick. They can still make people actually quite sick, but for Cambridge, we'll worry about that later. So we've had to humanize monoclonal antibodies. And the two ways in which we humanize monoclonal antibodies are altering the genes in the lab mice, creating transgenic mice and rabbits that code for the heavy chains of the antibodies of humans. So the lab mice and the rabbits that are creating these monoclonal antibody these hybridomas that produce our monoclonal antibodies are MABs, and yes, it is acceptable to use that abbreviation, make a human antibody, a quote-unquote fully human antibody made by mice and rabbits. But it's fully human because it's human DNA. It's fully human DNA. We can also alter the position of the carbohydrate prosthetic group found on the antibodies, so they are most closely resembling human antibodies. And this configuration in humans, they need to resemble the configuration of humans so the human immune system does not respond to it as readily as if it were an antigen, a non-self antigen. That glycoprotein, that identifying marker prosthetic group, allows us to recognize that it is or is not human. So we're tricking the immune system by making it look human, but it's not fully human. So these are maybe not terribly necessary, but if you see OMAB as the suffix for the drug, it's a mice with no changes. If it's Zimab or Zumab, XIMAB or ZUMAB, then it is a chimeric mouse and human where they just changed the carbohydrate group around. If it is UMAB without the Z, then it is a fully human where they used human genes to create the heavy chains of fully human transgenic mice. So we have our monoclonal antibodies now. What are we going to do with them? We're going to make money. It is a very big industry. They're used in biomedical research, they're used in diagnosis, they're used in treatment every day. We can use them for radio labeling things where we attach a radioactive isotope to a monoclonal antibody. For example, if we attach it to a monoclonal antibody for fibrin, we can allow them to circulate through a bloodstream to bind to fibrin-rich clots in the circulation. And when the fibrin-rich clot is found, the antibodies will bind to it in large numbers, and then the radioactive isotope, which will have been emitting radiation the entire time, will be emitting radiation in higher concentrations in that area, and we can find that clot. Then we go in with a catheter and fish it out. We can also use this to find cancer tumors by creating monoclonal antibodies for tumor cell markers. So that's cool. We can also use this for enzyme-linked immunosorbent assay, ELISA. When you do an ELISA, a direct ELISA is directly testing for the antigen. An indirect ELISA is testing for the antibody to that antigen. In both cases, you use an enzyme-linked monoclonal antibody for whatever you're testing to chemically react to the enzymes will lower the activation energy on a reaction that allows you to see a response, a chemical indicator. So this is a direct ELISA. The antibody is adsorbed to the well, the patient sample is added, and the antigen is bound to the antibody on the well. That's from the patient. This antigen is from the patient. They have this antigen. The enzyme-linked antibody specific for the test antigen is added, and that binds to the antigen here. and you create a little antigen sandwich with antibody bread. And this is an enzyme-linked antibody. You add you wash this to remove any free-floating excess, unbound excess. And then you add your indicator solution. The substrate will bind with the enzyme that is bound to the antigen. The enzyme that is bound to the antibody, that is bound to the antigen, that is bound to the other antibody, that is bound to the wall. E-I-E-I-O. Or rather, I don't know why she swallowed a fly. That's probably the more relevant one. And then that will change the indicator solution. You have your positive result. With no antigen in a direct ELISA, the antibody bound with the enzymes will not attach to anything. It will all be washed away, and the indicator will do nothing. In an indirect ELISA, the antigen is starting absorbed to the well, stuck to the wall. And the patient's serum is added. Why serum? Because that's where the antibodies are. Plasma and antibodies make serum. You add the patient's serum. If they have been exposed to an antigen in the past, they will have developed antibodies for it if their immune system is intact at all. So, they will have an antigen, and then the antigen will bind, and then the antibodies will bind to that antigen on the well. Then you'll have a monoclonal antibody specific for the antibody from the patient with enzymes bound to it. Then you wash away the excess, the free-floating excess. Then you add your indicator, and your chemical reaction proceeds, you get a positive reaction. If the patient has never experienced this antigen before, there will be no antibodies. No antibodies means that your enzyme-linked monoclonal antibody will bind to nothing. It will all get washed away, and your indicator will do nothing. You will have no positive reaction. You will have a negative reaction. So, there are also some therapies using monoclonal antibodies that we can discuss. Anything that ends in MAB, any drug that ends in MAB, is a monoclonal antibody medication. Trastuzumab is used to treat breast cancer. It works by binding to a HER2/neu receptor on certain breast cancer cells. You have to check to see if there are HER2/neu receptors on the breast cancer. If there are no HER2/neu receptors, Herceptin, or trastuzumab rather, will not work because antibodies are specific to their antigen. With no HER2/neu receptors, there is no antigen for this monoclonal antibody. It will not work. And this is a kinder, gentler chemotherapy. Infliximab is useful for a wide range of inflammatory diseases. For example, it is useful for rheumatoid arthritis. It is a monoclonal antibody that is specific for TNF-alpha, tumor necrosis factor alpha, which is a pro-inflammatory cytokine secreted by T helper cells. T helper cells secreting pro-inflammatory cytokines produce inflammation. And if an autoimmune disease or any inflammatory disease is mediated by inflammation, and you have a drug that targets a cytokine that causes inflammation, that promotes inflammation, and your infliximab, your monoclonal antibody, neutralizes the cytokine. You neutralize inflammation. You prevent inflammation. It works very, very well, and it is very expensive. It is extraordinarily expensive. Rituximab is used to treat a wide variety of autoimmune diseases. It's used to treat CLL. It's used to treat hairy cell leukemia. It's also used to treat non-Hodgkin's lymphoma, which is a cancer of the lymph tissue, the mature lymph tissue, not the stem cells. It targets CD20, which is found on the surface of B lymphocytes. So anything that is mediated by B lymphocytes will be suppressed by rituximab. So, your humoral immunity is suppressed by rituximab. Autoimmune diseases, which are mediated by antibodies, which are produced by plasma cells, which differentiate from B lymphocytes, rituximab will reduce the level of circulating antibodies all the way across the board. Leukemias, CLL and hairy cell, which have elevated levels of B cells, B lymphocytes. Hairy cell, which is specifically a B lymphocyte cancer. Rituximab specifically targets B lymphocytes. It reduces their numbers. But rituximab is not on the model list of a WHO list of essential medications for those reasons alone. It's on that list because of its ability to suppress immunity whole cloth. Without it, you can't have effective immune suppression for things like transplants. It is part of doing business as usual in modern medicine. So drugs, it is one of the best drugs, most effective drugs in its class for suppressing the immune system. The textbook also mentions ipilimumab, which is a monoclonal antibody that is effective in the treatment of melanoma. And that's all I know about it. You are better off looking that one up on your own, actually. Do some for yourself. So, let's talk about some old definitions that we're finally giving a name to. Active immunity and passive immunity. Active immunity is the specific immune response. It's the production of antibodies. It is the humoral immune response. Producing antibodies is active immunity. Through exposure to an antigen, you produce antibodies. Passive immunity is also antibody mediated, but you didn't create those antibodies in your own cells. The plasma cells in your immune system are not responsible for those circulating antibodies. But antibodies perform three functions, and it doesn't matter where they came from, they are still performing those functions. And those functions are neutralization, opsonization, and complement activation. Neutralization, they prevent the pathogen or antigen from doing its dirty work. Viruses are unable to enter cells. Toxins are unable to inhibit or activate the enzymes that they act upon. Or they're unable to enter the cells to act upon internal targets. Opsonization. They allow for Fc receptor mediated phagocytosis, or they allow for cytotoxic T cells to better bind to and fire toxic vesicles at cells. Complement activation. Antibodies attach to the surface of a pathogen cell, which allow for the activation of the complement system, which can directly kill pathogens. And it's important to understand why passive immunity is short-lived and active immunity is delayed but longer term. And also why passive immunity does not produce memory cells, whereas active immunity does. Passive immunity is immediate because the antibodies are given and they are able to neutralize and opsonize their targets as soon as they are present in sufficient quantities. They work immediately via specific antigen-antibody binding. Antigen specificity. Whereas active immunity requires activation of B cells. It requires T helper cells to activate B cells, and then they differentiate into plasma cells and memory B cells. And then the plasma cells can produce those IgGs and those immune globulins rather. And the immune globulins, it takes time for them to get up to sufficient sufficient levels in the serum. Now that we've added antibodies, it's serum, for you to have the effects. So it takes time, but it is longer term because you are not done as soon as you have used up whatever was injected. The plasma cell will continue to produce antibodies for as long as the plasma cell lives, which is not that long, admittedly, but it will continue to produce antibodies for as long as it lives. And whatever memory B cells are present and continuing to be exposed to antigens will produce more plasma cells. So as long as you have plasma cells, you will produce antibodies. And they will produce antibodies throughout their entire lifespan. So they last a longer time. Passive immunity does not produce memory cells. Passive immunity, when you are getting your antibodies from exogenous sources, exogenous, exo, outside, genus, born from the outside. An exogenous source, you are given the antibodies from somewhere else. Endogenous is the opposite, internal. Endo is inside. So, exogenous antibodies of producing passive immunity will allow for neutralization, opsonization, and complement activation. But memory B cells and plasma cells have not differentiated in order to produce those antibodies. And without memory B cells, activation of B cells will not occur in the future. Activation of B cells in the future will not occur unless you have a naive B cell roaming around like before. So you're only going to get a primary immune response in the future if it happens again. Your secondary response is the result of memory B cells that occurred, your active immunity rather, is the result of, your active immunity is exposure to an antigen that produces memory B cells and plasma cells. Plasma cells producing antibodies, and memory B cells forming the memory. And when that antigen exposure occurs again, the memory B cells will differentiate into plasma cells and more memory B cells, and those memory B cells and those plasma cells will produce more antibodies. So active immunity gives you plasma cells and memory B cells. Passive immunity, you got those antibodies without getting plasma cells. And plasma cells require differentiation. And the other part of differentiation, the other cell that can be differentiated are memory B cells. No memory B cells, no memory. No antigen exposure and no active immunity producing memory B cells, no memory. So here's some types of immunity. Your specific resistance is when you respond to a threat on an individualized basis. And you can have some innate immunity with a genetically predetermined protection against a disease, like sickle cell trait gives you a resistance to dying from malaria. You can still get malaria. You can still contract malaria. You can still you can still be exposed to and contract the Plasmodium parasites and then develop the symptoms of malaria, but you are less likely to die. You are resistant to malaria with sickle cell trait. So that's a genetically determined innate resistance / immunity sort of a deal. But an acquired immunity is what we've been talking about this whole time. It's produced by antibody production. Antibody production is the important part here. Active immunity is when the produced antibodies develop in response to antigens, an immune response. And passive immunity is when they're produced by the transfer of antibodies from another person or another creature. We can also break this up into natural and artificial. Natural and artificial. Naturally acquired active immunity and artificially induced active immunity, and natural passive immunity and artificially induced passive immunity. Naturally acquired active immunity is when you get sick, you develop a primary response, and then your secondary response is much stronger and faster. Artificially induced active immunity is like vaccination, where you are exposed through a artificial means, you do not get sick, and the next time you are exposed to the pathogen, you develop a stronger immune response, and you don't get sick. You develop immunity after administration of an antigen to prevent the disease. Passive immunity, you do not develop an immune response. There is no immune response. You do not form memory B cells. You do not form plasma cells. Natural passive immunity is conferred by the transfer of maternal antibodies from mom to the baby across the placenta with IgG and through the breast milk with IgA. Induced, artificially induced passive immunity is conferred by the administration of antibodies to combat infection, poisonings, and poisonings, I suppose. So antivenoms, antitoxins, monoclonal antibodies like IV immune globulin. Those are artificially induced passive immunity. So this is a reminder about vaccines and the primary and secondary dose response curves. The primary antigen challenge curves, you'll have a lag time. You'll have the primary response resulting in a circulating level of antibodies. And then you'll have your secondary challenge resulting in a faster, stronger antibody response. Rise in antibody levels. It will taper down and you'll have a circulating stronger level after this. Also recall herd immunity from when we discussed measles. Herd immunity, in an instance where you do not have herd immunity, you have a transmitting case or an infectious person, transmits the infection to a susceptible person, and then that susceptible person becomes infectious and transmits it to a new susceptible person. In herd immunity, an infectious person cannot transmit the pathogen, I should clarify, cannot transmit the pathogen to a person who is immune through vaccination or through other immune response. And then because they did not become an infectious person, they cannot infect or transmit the disease to a susceptible person. That susceptible person is indirectly protected from the transmissible infection, the transmissible disease, the infectious disease, by the immune individual. They are indirectly protected. So because of herd immunity, people who don't get vaccinated can still not become sick. So, some new definitions close to the end. The R0 is the number of people one person will infect on average. So, and the threshold is the level of immunized required in a population for herd immunity to be reached. The threshold for herd immunity. As our R0 rises, so does our threshold requirement. So the more infectious a disease, the higher the threshold percentage required for herd immunity. So for things like polio and smallpox, which have similar R0s, they have similar threshold percent. They have similar thresholds. Measles, one of the most infectious diseases known to man, has a threshold of 93 to 95% required for herd immunity. That brings us to polio. And FDR, our poster boy for polio. Polio is a viral infectious disease. It's still present in the world today, and it's actually probably the next thing that we're going to eradicate. That or guinea worm. And Jimmy Carter, our president, former president, is working on that. But it's not, guinea worm is not a virus though. Polio is a virus. So it's probably the next viral disease that's going to be officially declared eradicated. It's typically fairly mild. Most people who get polio will typically only get a fever and a sore throat. That's about it. But in about less than 1% of cases, that virus will attack the nerve roots, causing permanent physical disability and sometimes death. And given the high R0, 5 to 7, of the disease, and the mild symptoms, the disease can run rampant. The virus can spread through the community unchecked and create enormous high outbreaks. And so in a large population, that less than 1% becomes actually quite a large number of people with permanent disability. The first effective vaccine against polio was introduced in 1952. It was given orally on a sugar cube to get kids to take it. It was developed by Jonas Salk and his team, but it was a live virus which had a very strong immune response, but live viruses tend to come with some risks. You can't give them to immune-compromised persons for fear of it activating and causing the disease you're trying to prevent. And in some cases, it did, in fact, activate and cause polio. So yeah, that happened. The inactivated vaccine was developed in 1987, and the inactivated vaccine has no risk of converting to active polio. And that's the preferred form of vaccination today. And it is given by needle injection. So we've discussed vaccination for smallpox, measles, tuberculosis, and now polio. There are times that vaccines are just not available. For example, there is no vaccine for HIV. There is no effective vaccine for malaria. There is a vaccine for one of the species of malaria that isn't particularly effective, and there's a vaccine for cholera gen, the toxin that is cholera gen, but it's not particularly effective against getting rid of the bacteria, and we can't vaccinate everything. Vaccines aren't a magic bullet to cure everything, to prevent everything, because they don't cure anything, they prevent. But we should ask ourselves, how come we eradicated smallpox? How was smallpox special? Why did that one get eradicated first? And why have our other attempts been less successful? So there are a couple of ways to break this down. And I've broken this down into three categories. Aspects related to the vaccine's cost effectiveness is the first category that we're going to go into. The variola virus, the pathogenic agent, the causative agent, the pathogen, the virus that causes smallpox, is stable. And when we say it's stable, we mean it doesn't mutate. It doesn't mutate. Its surface antigens remain the same. So for every person with smallpox across the entire world, we had one vaccine that worked, and there were no mutations in the smallpox virus that we had to fight to develop a new vaccine that would cause that we have to outpace the virus. And no, we didn't have to try and beat the virus and keep ahead of it. It was stable. It wasn't trying to beat us in a foot race to cure, to vaccinate. We had one vaccine. And because we had one vaccine that always worked and never stopped working, we never had to spend the money to develop new ones. And it was dirt cheap. Very, very cheap. And it was so cheap to produce, we could produce it in mass quantities, enough for every man, woman, and child. So the vaccine itself was a live virus, vaccinia. The vaccinia virus was a harmless virus. It was a living virus. Well, if you can consider viruses living, which they're not, but unit 2. We didn't have to kill it. We didn't have to break it apart. We didn't have to incapacitate it. We didn't have to weaken it. We didn't have to add crazy stuff to it. All we had to do was introduce vaccinia to a person and let their immune system do the rest. The vaccinia virus did nothing. It was completely harmless, no symptoms. But live viruses produce a very strong immune response. So the effectiveness of the smallpox vaccine was near 100%. It was extraordinarily effective. It was so effective. And it was such serendipity that there just happened to be a virus that could just do that for us. Now, the vaccine itself, the vaccinia virus itself, could be freeze-dried, and it could be stored without refrigeration for up to 6 months. That means all you had to do was take a crate of the freeze-dried virus out to wherever you were going, with a bunch of reconstitution solution, sterilized water or saline, I forget which one, sorry, and you wouldn't have to worry about it spoiling. You would not have to worry about it spoiling. You just take a box of reusable needles with you, and the reusable needles was the other part of this. You didn't have to carry with you massive crates full of needles for all of this. Pre-packed syringes with dosages of this stuff. No. All you had to do was take a box of reusable steel bifurcated needles. And these needles were like a little tuning fork looking thing. Shaped like a little tine, like a little pitchfork, without the middle tine. Yeah, sure. Shaped like that. I drew it. That's good enough. And basically, you could reconstitute the vaccinia virus vaccine. You could reconstitute the vaccine, and you dip the needle into the vaccine, and you bring it out, and there would be a dose of the vaccine held between the tines of the needle by surface tension of the water. Cohesive surface tension, hydrogen bonding of the fluid would hold it together. And then you would jab that into the skin of the patient, and that would break the surface tension of the water, and then the vaccine would come out, draining the tine. And then you would remove the needle, dip it back into the vial, and jab the same person again. Put it back in the vial, jab it again, back, and continue till you were out of the little vial. And that was like maybe 15 times. It didn't hurt too much, or so I'm told. Although I might have been lied to, but who knows. Now, doing that why not just use a syringe with a needle attached to it? Well, because then you would have to dispose of the syringes. Then you would have to dispose of the needles. You couldn't reuse those. These, when you were done, you put them in a container and then you boiled your box full of needles and then you could reuse them on the next set of patients when you reconstituted a new vial. They were reusable, so it decreased your transportation costs. The administration costs went down. It was cheaper to get all of your stuff out to the site. You had less to carry, it cost you less gas, it cost you less weight, you had less equipment, and you could carry more vaccines with you. You could be out there for longer. All you needed was a fire and some water to boil. Maybe a tent if it started raining, because no one likes to work in the rain. So now the other thing I broke it down by, aspects related to the pathophysiology of smallpox itself. If you are infected with smallpox, you could be spotted in a crowd. You were not infectious until the mouth symptoms started, until the oral ulcers began. And when the oral ulcers began, you could see those. So you can spot people with smallpox in a crowd and say, you're going to quarantine. Everybody in your family who's touched your mouth sores, they're going to quarantine. If a patient survives the disease, the virus doesn't remain in the body to cause illness later in life. Not like chickenpox. Chickenpox, when you get the full body rash and then it goes away, later in life it can come back as shingles or shingles. And you can spread chickenpox through those shingles rashes. Smallpox, once it's gone, it's gone. It's not coming back. You're not going to infect anybody new. It's never coming back once you clear it. If you're lucky enough to have survived it, it's not coming back. The other benefit of the pathophysiology of the virus itself is that it didn't infect non-humans. Only humans, non-human animals were not affected by smallpox. There was nothing else to break in the transmission cycle. We didn't have to start killing all the mosquitoes. We didn't have to start separating out. We didn't have to start giving all the pigs antibiotics, all the chickens antibiotics. We didn't have to start keeping the mosquitoes away from horses or anything. Nothing. We didn't have to start removing animals from the situation. All we had to do was vaccinate the humans. All we had to do was worry about the people. There were also societal factors in play. And that's the last part that I break it down by. The youth involvement was big. 16 to 17-year-olds were instrumental in helping healthcare workers locate cases, especially in remote regions, way out in the middle of nowhere, out in the boonies. And I don't know why that was. Maybe they were offering them t-shirts. I helped eradicate smallpox and all I got was this t-shirt, was the stinking t-shirt. Maybe it looked good on a college application. Maybe prom was coming up and they didn't want to get the virus, they didn't want to get the viral rash or something. Or maybe they just wanted to do good things for the world. Whatever the factor was, they were involved and they helped. And so that was good. And those were your age group cohort. So follow in their shoes. Be like them. Do good works and cure the world of stuff. Have at. So why hasn't the measles vaccination program worked? Well, let's think about it this way. Measles is way more infectious than smallpox. If you walk into a room where a person had measles, if within 2 hours and you're not immune to measles, 90% chance you're going to get measles. So we need a 93 to 95% immunity in the population to achieve herd immunity. There's an R0 of 12 to 18. a person with measles is going to infect on average 12 to 18 people. Measles is infectious. Measles is infectious for a long time. Measles is infectious for 1 to 2 days before symptoms even start. Measles is infectious for the entire time of the prodromal phase before the Koplik spots, when you know it's measles. So you don't even know it's measles while you're infectious. It could be anything that has a fever and conjunctivitis and like coughing. That could be a whole bunch of things. Little kids get snotty all the time and start coughing. It could be anything. Who thought it was measles? So it's hard to quarantine that. And so the vaccine success rate is about 95%. That means that if 100% of the population received the one dose of the vaccine, that you'd only have 95% immunity in the population. That's just meeting our immunity requirements. That's meeting the upper threshold requirements for our threshold for herd immunity. That means that we need like 99 to 100% of the population to barely get there. That's not enough. Most countries don't get 100% immunity. In fact, no country gets 100% vaccination rates. 80 to 90% is much more common. Slightly above 90% is rare but possible. So what you need is booster shots. Booster shots are additional challenges to the immune system with that antigen. And you challenge the immune system with the antigen a second time to produce a secondary immune response, which will result in higher levels of circulating antibodies and additional memory B cells for that antigen, for future antigenic response. And here's the problem with that too, because of course there's problems with that. Getting people to schedule a follow-up appointment is problematic. Getting people to keep it is a Herculean task. So, getting everyone to get their first shot is not going to happen. Getting 100% of the population to get their first shot is not going to happen. Getting 100% of the population who gets their first shot to comply with the booster shots is also not going to happen. So achieving threshold for herd immunity in measles is the pipe dream. It's possible, but it's real out there. And for Cambridge purposes, that's the most likely thing they're going to test you on and award points for. They are not likely to bring up current social factors like the anti-vaccination movement, which was incited by the fraudulent claims of Andrew Wakefield and perpetuated by poor science, poor scientifically literate celebrity who have no scientific background. Anyway, this is the internet. I'm going to get a flame war started. No more. So we've covered why they can't be quarantined because we don't know it's measles for a while. We've covered the immunity issues. We've covered the social issues. We've covered the scheduling issues. We've covered the vaccination we've covered the vaccination effectiveness issues. We've covered the R0 issues. That's about how you would compare a vaccination program to another vaccination program. Comparing other vaccination programs like the vaccination program against tuberculosis to smallpox, it's a bit harder because the vaccination program against tuberculosis, the vaccination against tuberculosis is a terrible vaccine. It really works very poorly. It's a bad vaccine. And tuberculosis is a very infectious bacterial disease which has a lot of antigens, and it is highly mutatable. Measles, at the very least, is somewhat more stable. It is more stable of a thing. Tuberculosis is much more susceptible to antigenic drift. HIV, we will likely never, I won't say never, but we are very unlikely to have a vaccine for HIV because of how rapidly it mutates. So antigenic drift is a problem. Antigenic shift with big changes in the genome is a problem. Booster shots that I've discussed here is a problem. Long-term immunity is a problem, especially because booster shots are needed on a regular basis to maintain long-term immunity. Sometimes that immunity is short-term. Sometimes it only lasts for a certain period of time, like the tuberculosis vaccine is a short-term immunity. The choleragen vaccine, the one against cholera, the toxin in cholera, is a short-term one. It doesn't last for that long. So, and antigenic concealment, which is why we have such difficulty with creating an effective vaccine for Plasmodium. Plasmodium species live most of their life cycle inside of cells. So you can't create a vaccine to produce promote an antibody response to something that is not outside in the serum for antibodies to bind to it. Because if it's not in the serum, antibodies will not bind. And that is the long and the short of it. And this is also, I will likely post a link in the description for this. This is far more advanced of an overview. It includes very specific chemicals, but it's written by a Cambridge University professor, like their actual Cambridge University. And because of that, I don't know your enemy. With that, we've concluded all of AS level biology in 3 weeks. Whew.